Thank you very much. When I prepared this talk, I was not ready to the results that we had in our session last evening, so I had to slightly modify my presentation based on that. But I think we can basically give the flavor of the whole story a little bit beyond what are the results of yesterday evening. We know the problem of increasing AKI in a case of requiring or not requiring renal replacement therapy, and this increased tremendously the cost. We know that we have precipitating factors, and among them, sepsis is one of the most important. And when you have sepsis and septic shock, actually the incidence of AKI increased dramatically. Now, we know today that patients with septic AKI tend to have a lower survival due to the comorbidity involved in sepsis. We know that AKI is common. Septic AKI is even more important and responsible for about 50% of the AKI in the ICU. And septic AKI is somehow something to worry about. Now, in terms of understanding of the septic mechanism, we must analyze the whole history of AKI. And when we thought that all the lesions were basically ischemic, we were probably making a big mistake. As Rinaldo Bellomo has shown this morning, in patients with sepsis, there is a kind of bypass of the circulation through specific collateral arteriolar network that somehow impedes the glomerulus to work properly. Now, how does it work? It works because infection, the immune response, and finally the organ damage move from the molecular, let's say, damage to the cellular response, where LPS is incorporated, opsonized, and activates several mechanisms. There are humoral and cellular effectors, and finally, not only through the microcirculation, but through the entire immune system, organ damage may occur. We have seen that the PAMPs enzymes represent important molecules. One is derived from the pathogen, the other is derived from the host, called damage-associated molecular patterns. And among them, we should remember that while this is an area of so-called mediators, here we have molecules that may be the so-called causative molecule for sepsis, including LPS. Now, the lipopolysaccharide activates at different cellular level a series of protein systems, the vascular and tissue cells, blood and lymphatic cells, leading to a series of effects that start as a biological effect and end up as a functional effect, because most of them include an action on endothelium and specifically, therefore, in organ damage. Therefore, the extended sepsis model, as proposed by Rinaldo, shows a particular dissociation between the flow to the kidney and function. We do not have the classic ischemia reperfusion lesion. We have to recognize the important role of mediators, and the pathogenesis is well described by this paper of Fernando Gomez in Shock a few years ago, when he describes very well the interaction between the tubular cells and the microvasculature and the mess, we can say, that occurs at the cellular level, where the energy of the cells is impaired, leading to potential apoptosis. Everything starts with the presence of endotoxin in blood, and we know that survival is impaired in patients with higher level of LPS. We have guidelines from the Survive Sepsis campaign. We have suggestions to try to modulate the immune response. However, if you look at the results proposed by several randomized controlled trials, negative, 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 negative. There was a positive activated protein C results, and then finally it resulted again negative. So the concept of adjuvant therapy in sepsis is somehow something that is extremely disappointing, probably because sepsis is not one molecule disease, at least after the cascade has been activated. And we know that the concept that patients were hyperinflamed today is still present because some patients die because intractable inflammation. However, some patients actually die because they have a significant immunosuppressant. So we may say that we have an immuno dysregulation, and we have proposed this actually in 1995 in this publication in Artificial Organs, when we said whether you have a sequential mechanism of inflammation and immunodepression, or you have a simultaneous stimulation and depression of the immune system, probably renal replacement therapies and extracorporeal therapies may represent a tool to cut down the peaks of these mediators, restoring part of the immunohomeostasis. And today in the afternoon, I will show how much our sorbent technology can actually help in reducing the level of inflammation. We have new sorbents today. We can speak about cytosorbents, Jaffron system, Kaneka system. So we have several sorbents that we can actually study in this thing. Of course, if you try to remove endotoxin from the beginning, this could be a promising approach, and you know that we can do that with a direct hemoperfusion on a polymyxin B immobilized cartridge that actually has demonstrated the capacity to remove significant amount of endotoxin both in vitro and in vivo. The story of this device started in Japan and evolved into Europe and finally into North America and Canada. People say, okay, sometimes less complex therapies and less expensive are successful. Not always blood endotoxin level is high, or not all sepsis are by gram-negative bacteria, leading to the presence of endotoxin. Studies often are underpowered, single-center, country, mixed population studies. More evidence is needed. So we started a process. We went through a meta-analysis where we actually analyzed a series of randomized controlled trials and non-randomized studies. And in both cases, we found some data favoring the use of PMX. In particular, in the meta-analysis and systematic review we conducted several years ago, there was a significant reduction in mortality produced by the application of polymyxin B hemoperfusion compared to conventional therapy. So in this editorial, John Kellum was proposing that further studies were required to somehow characterize the efficiency and efficacy of this device. And this is exactly what we did and published in JAMA a few years ago, the so-called EUPHAS trial, where we demonstrated the change in SOFA score at 72 hours for total, cardiovascular, renal, and respiratory. But the astonishing, interesting result was a significant reduction in mortality that was in patients that significantly required inotropic support, vasopressor support, and had significant respiratory and renal dysfunction. This effect was not only at 28 days, but remained at hospital discharge. And curiously enough, there was a kind of very much interesting similarity between the results from the meta-analysis and our EUPHAS trial. So in conclusion, that preliminary study was definitely describing a reduction in mortality at 28 days. And this is one single-center study, so it required probably a little more confirmatory data. However, the concepts and facts that could be reported is that sepsis is a deadly condition, still very high mortality. Pharmacological approaches are unsatisfactory. I want to speak later on about this high mortality concept. Often high endotoxin level in blood, and this correlate with outcome. The rationale is to remove it. Endotoxin removal techniques are available, and this system is decreasing mortality and improving organ function in patients with abdominal sepsis. In our study, we recruited specifically patients with sepsis severe and septic shock from abdominal surgery. So the UFAS trial opened new avenues, and because further confirmatory proofs were required, we had two approaches. The European approach that moved to a UFAS 2 with phase 1 and 2, and the EUPHRATES trial in North America. The UFAS 2 was basically, in phase 1, an observational retrospective analysis on a registry of applying thoramycin device to a large population, while phase 2 is observational prospective. The aim is to describe the efficacy in the field, in current practice. Now, you know that, of course, retrospective and registries have limitations because they have no control system. However, we published the protocol, and we know very much what are the limitations, but also what are the advantages of doing this, which describes what happened in everyday practice, not excluding this and that patient. This is the paper that has been published. The first name is Cutuli, but the group is quite large in Italy. And what we found was a different source of infection in our patient group. Interestingly enough, we had 41%, approximately 42%, that were abdominal patients. This is important because to a certain extent, this reproduced very much the patient that we studied in the UFAS trial. And in fact, look at the superimposition of the results at 28 days. There is absolutely a confirmation of the data of the UFAS trial in the so-called UFAS-like group. The prospective, let's say, RCT UFAS was proposing some results. The retrospective phase of the UFAS 2 confirmed these studies. And again, I want to show clearly the difference at 72 hours of several of the typical parameters that we analyze in sepsis. The UFAS 2 prospective registry is a typical kind of pragmatic trial in which we analyze the results in the practice. And what this registry add to the knowledge? Well, they are ideal for obtaining real-world effectiveness data. And I think that because septic shock is a complex disorder and there are many different causes and effects, I think it's important to collect data on a substantial number of parameters and patients. I must also acknowledge that we had some conflicting results, and these are the results from Didier Payen in a study where he concluded no difference in treated patients with or without PMX system. However, one of the interesting things about this study was that the mortality of the control group was less than 20%. So these are not the typical patients that we characterize as severe patients. If the mortality is 15% in the control group, how can we further improve mortality? These patients simply don't die. So it's a very strange population that was studied. Plus, almost 40% of the per protocol patients enrolled did not receive a complete therapy, so they were protocol violators. And therefore, this is complicated, and that's why I think Massimo Antonelli and myself wrote this editorial inviting to cautiousness, especially in light of the fact that we analyzed safety data in Italy from several different centers, on approximately 400 patients and almost 1,000 cartridges used, you see that the level of complication was quite low. And in particular, catheter clotting was in the range of 4%, while in the DDA-PAIN study was reported over 30%. What about Euphrates? Well, this is a unique study because it was prospective and it is blinded, randomized, control, standard of care versus PMX, several intensive care units in the United States and Canada. It was subsequently modified, the sample size, and recalculated because of the severity. But what makes unique this trial is the fact that for the first time, a diagnostic test and evaluation of endotoxin was the trigger for applying the system. The other thing was that it was a blinded trial and the recruitment was managed by a special committee. So basically, the number of patients that received an analysis higher than 0.6 were the patients that were included in the study. Now, we have information about the results from yesterday evening. The trial did not meet the primary endpoint, but showed a non-statistically significant mortality reduction at 28 days, which was higher than 5%. And that was very important because we found that some of the patients should be somehow analyzed for further secondary analysis. In fact, further detailed analysis have shown that there appears to be an upper limit to a patient pre-treatment burden of endotoxin as measured by endotoxin assay, above which the trial could not demonstrate benefit for the PMX cartridge. This magnitude of burden when endotoxin assay is greater than 0.9 has recently been described in an article in press for a common publication. Actually, this is being published in Blood Purification a few days ago now. And it shows clearly that when endotoxin level is too high, there might be a limitation in the capacity of absorption, but there is also a limitation in the detection because of the exponential correlation between values and concentration, and there is a limited accuracy in the test. In patients with septic shock and MODS higher than 9, baseline endotoxin between 0.6 and 0.9, PMX treatment demonstrated an absolute reduction in mortality of 14% at 14 days, 10% at 28 days, and 11% at 90 days, especially these patients in general were showing a relative reduction in mortality of 30%. Or even higher compared to the data that have been presented yesterday. These data that I reported are based on a specific press release. So I think that in this patient population, the improvement in organ function was seen, and this is extremely important for the further analysis of what we should do. How are we with the situation? We had several trials with wrong targets, no results. We had antibodies against LPS, right target, but the wrong method. The UFAS had the right target, the right method, right population, but small size. The Euphrates has right target, right method, right size, right population, question mark, because this suggests to personalize the treatment to specific treatment. And the UFAS-2 is a typical pragmatic trial registry that we should probably analyze better. So the future of intervention is probably linked to endotoxin removal only for high-risk patients with high mortality. Adopt dynamic prescription criteria is important, including biomarkers. What do I mean for this? Well, I mean that if you apply to the general population, you may have effect, no effect, or even adverse effect. But if you use patients with sepsis and you measure endotoxin assay, you can target the therapy to a specific population. So as you do for azotemia, when patient is climbing and you prescribe a certain dose of CRRT, you have to modify your prescription. The same is true when you have a climbing level of endotoxin assay and you may want to prescribe polymyxin B especially when they are between 0.6 and 0.9. This is exactly what we discussed yesterday evening. An integrated and sequential approach is required for sepsis, where this is not the panacea. This is not resolving the whole system. It requires also antibiotics, a timely endotoxin removal, the immunomodulation with extracorporeal therapy. So absorption may follow this treatment, absorption of mediators or removal of mediator with CPFA and hemoperfusion. Adequate renal support, condition favoring renal recovery, avoiding this endothelial to mesenchymal transition that yesterday Castellano presented very clearly. And finally, personalized therapy, precision CRRT. What is precision CRRT? What ADKI has advocated. So technology in CRRT may help in different moments of the history of the patient. But if you have an endotoxin assay positive, you identify the therapy target, and you prescribe the right target. Now, what I want to show you is exactly this to conclude. If you have a patient that is not sick, the DPIN population, they survive no matter what. If they are very sick, endotoxin assay to the sky, they may die no matter what. But in between, there might be a population that benefit from the intervention. So when you plan your study, and this is the study analysis of patients between 0.6 and 0.9, the difference may become highly significant, 30% relative difference. However, what we have to work with now is the tails. These patients, are we applying futile therapies, or should we do anything for this patient to avoid this patient to move in a higher severity level? Or in the more severe group, do we have to increase the removal of endotoxin? Maybe do we need to do more sessions, longer sessions, higher capacity for removal? This we don't know, and this will be probably an area of research for the years to come. Thank you very much.